So I'm going to stop sharing my screen. Dr. Amnahash Bijan, if you want to go ahead and share your screen as I'm giving the intro, we can definitely do that.
Sure.
But the time is now noon, so we are going to get started. I want to thank everyone for joining us today, for taking time out of your schedules. So the time is now noon, so we're going to get started. And my name is Tracy Summer. I am going to be helping to facilitate today's webinar hosted by Max. And those who are not familiar, Max is on the Maryland Addiction Consultation Service. We provide support to prescribers and their practices across the state and their healthcare teams in addressing the needs of their patients with any substance use disorder or pain management. So all of our services are free, including phone consultation for clinical questions. We help with finding resources for you and your practice and your patients. We do a lot of education and training, such as today's webinar. We also have our technical assistance to practices expanding or implementing their office-based addiction treatment, as well as our tele-echo clinics and our Max for Moms program, which supports providers with questions about patients who are pregnant or in the postpartum period, also with questions about addiction treatment or pain management. Um, I do want to take a minute just to also share about a new resource that actually just came out with Max. As medetomidine continues to emerge in the illicit drug supply, staying informed on the clinical trends is definitely vital for patient care. We recently published a video overview featuring Dr. Burnett and Dr. Olson discussing the emergence of medetomidine and the critical insights that healthcare providers need to know. Along with the video, our team has developed a comprehensive suite of materials and a library to support providers in navigating this new landscape. So our updated collection will feature today's webinar that will be recorded, as well as a Max fact sheet and additional links and recordings. Thank you, Marciel, for putting the information into the chat. You can go to the link to view that video and recording, and also a link to the tools section on our website as well. Before we dive in, I do want to go over some housekeeping items and the process for earning credit for today's training. You can use the chat during today's webinar if you have any questions, and there will be time at the end. A copy of the slides from today, as well as a recording, will be uploaded to our website within 1 week. It will also be sent to you by email after today. The process for earning credit, I know that is definitely of interest, but in order to receive, CME or CEU credit, which today's webinar is offering, you must be online for the full duration of today's training, and you must complete the evaluation survey within 7 days from today. That survey will be available immediately after today's training by logging into your OASIS portal. And you can complete that survey, and then you'll be able to download your CME and your CEU certificate directly from that portal. I'm now happy to introduce our presenter for today. So today we have with us Dr. Jordan, and I apologize if I
You could,
mispronounce.
Dr. Jordan's fine.
Thank you. So Dr. Nahash is an assistant professor of medicine in the Division of Addiction Medicine at Johns Hopkins Bayview. She trained in internal medicine, and in 2023, she completed the practice pathway for addiction medicine certification. In this role, she treats patients for a variety of issues unrelated to substance use. She is a primary care doctor at the Comprehensive Care Practice and works on the Addiction Medicine Consult Service at Bayview. She teaches medical students and residents and fellows in topics of addiction medicine. She has an interest in improving care in prisons and jails, especially expanding access for medications for OUD. She also has a She also has a more recent interest in emerging drugs and their clinical syndromes, which helps us bring to today's talk. So thank you so much for being here. I know this is such an important topic, and I'm now happy to pass it on to you.
Thank you, Tracy. Thanks for all your help. And thank you, everyone, for being here. As a disclaimer, I'm not good at talking and monitoring the chat at the same time, but I welcome people to jump in with questions or comments. I know I saw in the chat that some folks are from places like Cecil County, which has seen a ton of medetomidine alpha 2 agonists. So I welcome your input as well. So please feel free to speak up, or if Tracy, if you see anything in the chat that's time sensitive, I'd be happy to address it in the moment. So my name's Jordan Nahas Vigon, but you can call me Jordan. I am in the Division of Addiction Medicine here at Bayview, and today I'll be talking to you about the recognition and management of alpha 2 agonist intoxication and withdrawal. Initially, we were calling the talk, medetomidine and alpha 2 agonists in the illicit drug supply, but I think that that this encompasses a little bit more broadly speaking with the emerging drugs now. So let me make sure that I'm here. All right, so no disclosures. And then our objectives today is to define what an alpha 2 agonist is. What does intoxication look like? What does withdrawal look like? How do I treat it? And then throughout the talk, just thinking about what some of the systems issues are. And then I'll go, I have a slide sort of dedicated to the systems issues, but also just as you're going through this and thinking through your particular workplace and your particular community, like how that can be affected by these emerging drugs and dangerous withdrawal and intoxication syndromes. So what is an alpha 2 agonist? So the full name is the alpha 2 adrenergic receptor agonist, but we shorten it to alpha 2 agonist. So alpha 2 receptor is is part of your nervous system, both your central and your peripheral nervous system, but we focus in this talk and with the medetomidine in particular on the central nervous system. And it basically reduces norepinephrine and that reduces your sympathetic drive. So if you think of like your sympathetic and your parasympathetic nervous system, the sympathetic is that fight or flight, and the parasympathetic is that sedation. And so the alpha 2 agonists reduce that sympathetic drive. And then when you take it away, you have a burst of that. And so thinking about the mechanism of action can sort of help, as we go through the talk, help you think of the both the intoxication and the withdrawal syndromes that come with it. So alpha 2 agonists have been used in human medicine for a long time now, and they're medications that you may recognize both from adult and pediatric populations. So they're used for blood pressure, for muscle relaxation, for sedation, and you may recognize them as clonidine, lofexidine, tizanidine, guanfacine, and then dexmedetomidine, or Precedex, which is by infusion only. And then now, only recently, really, have we come to realize that alpha 2 agonists are actually used in veterinary medicine for sedation, namely xylazine and medetomidine. And that was truly not something that I was ever aware of. It was before xylazine started being more prevalent in the last 5 years, and then medetomidine in the last couple of years. So these animal sedatives are not approved for human use. They were tested in humans initially and deemed to be unsafe. So xylazine was actually first reported in the drug supply in the mid 2000s, like early to mid 2000s, in Puerto Rico and Philadelphia. And so when comparing it with, say, clonidine, it seems to be slightly less potent than clonidine, but it is dose dependent in the hemodynamic effects. So you do get some of that sedation, decreased blood pressure, decreased heart rate with the xylazine. But but maybe not as profound. It doesn't seem like it's maybe quite as tightly bound and specific to the alpha 2 receptors. And so you'll see that it actually comes with a little bit of a different syndrome, but it is really associated with the soft tissue wound. So I think probably a lot of folks on here have seen skin and soft tissue wounds related to xylazine. And what I find interesting is that, the wounds probably were around for many years, but they really only appeared in the academic writing and literature starting around 2020. But even before that, the harm reduction agencies were out there with wound supplies and really meeting patients where they were at before it became more of an academically recognized issue. But the wounds became so bad, and the consequences of sort of the sedation with the xylazine were so significant that in 2024, Pennsylvania scheduled xylazine, making it a lot more difficult to come by. And that really opened the door for medetomidine. So, medetomidine, for folks who took organic chemistry, is a racemic mixture of the dexmedetomidine, which we use in clinical medicine, and levomedetomidine, which is not part of clinical medicine. And it's about 200 times more potent than the xylazine. And it was actually first detected right here in Maryland in 2022, but it was more of a one-off kind of detection. It was just scattered around here and there and wasn't really thought to be that clinically significant. But then what we see, and this is the Philadelphia Health Department has done such a terrific job of putting this into graph form. So I'll show you here. Here is May of 2024, which is right about when xylazine was scheduled. So can you all see my mouse? Hopefully moving. Okay, thanks, Tracy. So xylazine's at 100% of the drug supply here leading up to May of 2024. And then it was scheduled and it rapidly drops down by quite a bit. And medetomidine has this window to come in and take firm hold of the drug supply. At that same time, you can see here again, 2024, when xylazine is scheduled, the emergency room visits for skin and soft tissue injury related to substance use dramatically fall. And then at that same exact time, emergency department visits for withdrawal, which typically had been stable for many years. I mean, you could see a slight increase here, but really for many years had been quite stable in terms of patients seeking emergency room treatment for opioid-related withdrawal. It has this huge spike once medetomidine hits the drug supply. And so that's really what we'll be focusing on. How do we even know what drugs to look for, though? I think that now that we've been exposed to these different substances, it's opened up this sort of previously unknown to me world of emerging drugs and substances that are in the synthetic drug supply and the illicit drug supply. So how do we even know what to look for? And I think that we can look at many different levels. So the individual, local, regional, and national. So the person who is using drugs or with someone who's using drugs can have test strips. There are fentanyl, xylazine, and medetomidine test strips that are available. The challenge is that you have to know what substance it is that you're looking for. You have to have the test strips made, right? And somebody does, not you particularly, but somebody has to make the test strips. And then you have to deliver the test strips, distribute them, and do a whole bunch of patient education about why we're even testing for this substance. So the individual can report back like, hey, I'm seeing this and this, or I'm experiencing this and this that's different. And then you get up to that local harm reduction level where people, clinicians, social workers, behavioral health, they're listening to that. They're saying, here, my patients are saying this is different. We should be thinking about something else that's in the supply or some other issue that's going on in the community that is leading patients to experience these different things. And then you get up to the more regional levels. And the health department's been a huge help for me and my practice here at Bayview in determining what substance we're dealing with and how to approach it. The health departments can put out bulletins that are helpful. The Poison Center, the Maryland Poison Center is really helpful in sort of as a repository of information of, okay, we're seeing a lot of this calls for this or that. They can be a tremendous resources. And then Max, the addiction medicine consult service here, I've recently now been talking to some people in different states, and they really have so few resources. And when it comes to drug tests, there are states where drug testing is actually illegal. And so we actually do in Maryland have a ton of really great resources to help guide our clinical care. And then more nationally, I now get emails from NDUS and CSFRE. NDUS is the National Drug Early Warning System, and CSFRE is the Center for Forensic Science Research and Education. Sorry. And so they are doing tons of extensive toxicology screening, and they report back to communities as well. So there's a lot of different ways that we know what to test for. And Maryland now has this dashboard of what drugs are being tested for around the state. So I know there's a few people I saw in the chat, at least a few people on here from Cecil County. So that's in orange here, and then Baltimore County, and then Baltimore City. Forgive my redistricting lines here, but that's a general sense. And so the Maryland Health Department now, they partner with the syringe service programs, and they test the substances at a variety of different syringe service programs across the state, and they can see what drugs are in the paraphernalia or the actual drug itself that's being tested, and then they report that back to the syringe service and the person who brought the supply in, as well as now a public-facing dashboard, so we all have access to it. And what's so interesting is that the regional trends, it's actually like even each county is so different. So this is Baltimore City, and this is over the last 6 months. And this is patients who brought in, a drug or a supply of some sort to a syringe service program. And this is what's in the drugs. And just as a caveat, these are patients who are using the syringe service program. So it's not representative of everybody who uses drugs in Maryland or in the city. And it's not maybe representative of the people who are going to the hospital for substance related issues or people who are not using syringes. So this is a subset of the population, but it's helpful to get a sense of what's out there in our communities. So a lot of filler in the Baltimore City supply, and then mostly fentanyl. And then you come all the way down here, and Medetomidine actually over the last 6 months has been a pretty small portion of the Baltimore City supply, but it is there. And then this is Baltimore County, which looks very different. Similar in the sense that it's fillers and fentanyl, but not a lot of other stuff in there. You still do have a good bit of xylazine though. And then if you go to Cecil County, you can see majority fentanyl and medetomidine, so really big. And again, these counties are so close together. And I will just go back to the map real quick to show that Philadelphia here as the epicenter, and then it takes the drug supply, it seems like takes this route here to get to Cecil County in northern Delaware. So the other thing I'll just say, this slide is busy, but it's just highlights that there's so many emerging drugs out there and drug combinations that it is helpful to partner with either a local or regional organization and just understand what the drug supply is, or to even get the mailings from the different national organizations as well that can give us some idea. So this one over here is the National Institute of Standards and Technology, and they show you what's on the West Coast supply and the East Coast supply across the last 3 months. And certainly very different for each. So medetomidine here, West Coast 3% and East Coast 30%. And xylazine at this time, there was almost none on the West Coast, and then 26% on the East Coast. Of course, there's mass overdoses that happened in Baltimore this last summer. There's this new synthetic opioid called an orphine analog that seems to be emerging in the drug supply. New and novel benzodiazepines. And then I'm not sure if anyone saw the New York Times article, and this is the daily podcast that focused on the synthetic cannabinoids in being smuggled into the Cook County jail. So basically, that's all to say that there's so many substances out there, and we don't all have to know every single one of them. But of course, it wouldn't be practical or feasible. But just knowing that if a patient says this isn't what I'm used to or this doesn't feel right, that's probably true. So this is also part of the RAD database, and it from Maryland, from all the samples in Maryland over the last 6 months, only 20% were the expected substance that people thought it was going to be. And 40% had some of the expected substance, and 40% had nothing that was expected. So it was a completely different combination of drugs than somebody thought they were buying. So bringing that to what we're seeing clinically here, our experience at Bayview. So we have what's called an addiction medicine unit here at Bayview. And this is a 12-bed unit in the hospital. It's non-monitored, meaning patients aren't hooked up to a continuous pulse oximetry. We're not continuously monitoring their blood pressure, their heart rate, their oxygen. But we do have 2 nurses who are working there for the 12 patients, and they're around the clock. The providers are usually there. There's one provider that's there, a nurse practitioner or a PA, usually from 8 to 4 p.m. And then the attending comes in to see all the patients at least daily, and we're available on call overnight too. But I say that to say that it's not it's not emergency room level care at the AMU. But patients can make an appointment to come in for treatment of withdrawal. And historically, this was alcohol withdrawal, benzodiazepine withdrawal, and some opioid withdrawal. And now we are seeing more of this as the medetomidine withdrawal. So I'll tell you sort of the story of that, which was starting in October of 2024. We saw our first patient with, now in hindsight, what was medetomidine withdrawal. But to me, it just looked like this horrible, horrible opioid withdrawal that I had never seen before, something so awful before. But we managed to get through it. That patient then came back in January, and a colleague saw that patient and said, you know what, this cannot possibly just be opioid withdrawal. What else could it be? So she phoned a friend of ours in Philadelphia who said, oh, this really sounds like medetomidine withdrawal. We really had no idea what we were dealing with. But we then connected with some regional partners, the folks up in Cecil County and Delaware at Christiana Care. Greg Warner and his team have been super helpful. And we actually got connected with the CDC as well, because they were doing a deep dive into the emergence of medetomidine in the region as well. And so through talking to lots of people, we've been able to sort of collect a lot of information about how to best treat patients with medetomidine withdrawal. But it's still an evolving, I would say, field. So working with our lab, at the time, there was no lab test, no approved lab test for medetomidine, but it was in process. And so our lab director was able to test a few of the suspected cases. And the first 10 cases we sent based just on the fact that the patients were from Cecil County and they had a clinical syndrome that seemed consistent. They were 100% positive for medetomidine in those patients. So then we said, okay, we really know what to look for now because we're seeing these same clinical syndrome. I'll pause there. Any questions or concerns or notes that people want to add? Okay. So before I move on to
We did have a question.
yeah.
Apologies. So there is a question. Someone put in the chat. They said, "I see that heroin is on the low side now with fentanyl on the rise." And then they asked, "How many days do they stay?"
Oh, okay. Yeah. Heroin is like really hard to find. There was actually there was a period earlier in the year where I had 3 patients who said they were using heroin. And usually I'll say, well, there is no heroin. And they said, well, I purposely use heroin, so I know I'm using heroin. They were using heroin. It showed up as heroin in their drug testing. But there is almost no heroin around now. It's almost entirely fentanyl. And then how long the stay is for the AMU. The typical stay for up until we started having more patients with medetomidine would be 3 days. So 3 days for alcohol or benzodiazepine withdrawal, or even opioid withdrawal. And now it's really variable. So, I mean, still for alcohol and benzodiazepine, it's still the same 3 days, but with for medetomidine withdrawal, it ends up being longer, and I'll get into that in a little bit. Um, so as far as medetomidine intoxication goes, so what people were noticing in Philly when they realized they needed to look for another substance is that these really severe cases of sedation and bradycardia that were not reversed by naloxone. And we see this when patients come in to the AMU for a scheduled intake for opioid plus medetomidine withdrawal. So they will be sedated, but they do have to be able to come in and sign the papers. So they're not, completely obtunded, but they are rather sedated. And then they have very profound bradycardia. So heart rate in the 30s to 40s is pretty common. And then the hypotension is moderate, probably about 90 to 100 systolic. And the patients who we're seeing do not require that walk into our clinic, right? To walk into the MU, they do not require naloxone for reversal. But if you are concerned about overdose, then naloxone is still absolutely the first step in treating an overdose. And restoring breathing. So really, like, that's the purpose of naloxone, right? It's to restore someone's breathing if they've stopped breathing. It's not necessarily to wake them up. And so they may still be sedated. You may still have profound sedation, but at least they're breathing. And we don't find that patients typically need heart rate or blood pressure support in this sort of intoxication or even overdose phase of medetomidine or alpha-2 agonist. I will say, just a caveat, I know I say that naloxone is like the absolute #1, but if you have there are these more compassionate ways to treat overdose if you have the support for it, supplemental oxygen as opposed to naloxone, but that is a whole talk for another day. So I don't want to overlook the fact that there are places that are using oxygen, but for the person who is walking by someone on the street who is overdosed, really what you want to go to is naloxone. As far as the withdrawal, so what we're seeing is that withdrawal onset can vary. It can be from about 4 hours to up to 24 hours after the last use. And the symptoms are both the typical opioid withdrawals that we're seeing, and then we're seeing these extra severe symptoms that are really more specific to medetomidine and alpha-2 withdrawal. I will say we don't see a lot of withdrawal from xylazine. maybe a little bit of agitation, but there does not seem to be a distinct xylazine withdrawal picture that is clinically significant. One thing that when the patients come into the AMU, I think it's always really important to assess for alcohol and benzo withdrawal risk, because pretty soon they are going to feel so bad and they are going to look so bad that we're not going to be able to tease apart whether alcohol or benzodiazepines were part of the picture or not. So I really make sure to get a good history at the start. So as far as the withdrawal symptoms you get the typical withdrawal. Opioid withdrawal can be the body aches, the sweating, yawning. Certainly you can have that, but then you get these added atypical symptoms or alpha 2 specific that are severe vomiting, severe agitation, these shaking rigors that some people feel look like seizure activity because it's really full body shaking. And then the patients are pretty high risk for delirium as well as mutism. So they sort of don't talk a lot when they're going through the withdrawal. And again, that's part of the reason why getting a good history up front is really important. As far as their hemodynamics, we're getting blood pressures in the 180s to 200s, systolic, tachycardia with the heart rate, probably around 150 beats per minute is average. Some patients do have fever. And then we do get a very significant on labs leukocytosis. So patients might get their labs checked when they first come in and their white blood cell count is totally normal. And then 4 hours later, they're going through withdrawal and they have a white blood cell count of 25,000, which really highlights the sort of inflammatory response that the body has to the withdrawal. And then we do get severe electrolyte disturbances. For typical withdrawal treatment, we are certainly, opioids are the treatment of choice. I will say, if you all use COWS scoring in your practice, we're seeing COWS scores in the 20s to 30s. So people are very, very uncomfortable in their withdrawal. I think I'm just trying to paint this picture of how uncomfortable and how miserable people feel. So we lean a lot on methadone for the withdrawal management because it is long acting. And then we supplement with oxycodone and hydromorphone as well. The nice thing about methadone and hydromorphone is they can also be given IV for when patients are no longer able to tolerate PO or oral medications, which we'll get to in a little bit. And then I also like to discuss medications for opioid use disorder or MOUD. I like to discuss that early with patients because we want to use this hospitalization as an opportunity to help them to get onto medications for their opioid use disorder. So whether that's methadone or buprenorphine, we want to start that as early as possible so that we can set patients up for success at discharge. For the atypical symptoms, the severe vomiting, agitation, those really require alpha 2 agonists. So in the beginning, when I said the list of medications that we do use that are alpha 2 agonists, we do use in human medicine, that's clonidine is the mainstay of treatment for at least initial withdrawal management. So clonidine alpha 2 agonist. We stick on a clonidine patch almost as soon as patients get in the door. The clonidine patch takes about 24 hours or more to kick in, so it's not going to be effective. So even the patient with a heart rate of 45, we order a clonidine patch, we get a message from the pharmacist being like, are you sure you want to do this, right? Because it's atypical that you would order a clonidine patch for somebody with a heart rate of 45. But we put on a clonidine patch. And then once their heart rate is above 55 or 60 and their systolic blood pressure is 120, we start giving oral clonidine. And for those who do not prescribe clonidine very often, these are doses you will never see in any other context. And for people who do prescribe clonidine, I know you'll be kind of floored by how much we're giving, right? So we're giving zero point 0.3 milligrams of clonidine every 1 to 2 hours for the first 3 or 4 hours of treatment. And then we try to space it out to 3 to 4 hours after that. We sort of are doing a clonidine load. Um, and again, remember, this is a non-monitored setting. So patients are not on continuous blood pressure or heart rate monitoring. There's not a provider there all the time. So if you are in a setting where you do have really active monitoring, you can have somebody on a continuous blood pressure or heart rate monitor, nurse checks every 15 minutes. You can probably be more aggressive. And there are places like Pittsburgh, they're doing clonidine dosing every 15 minutes for the first hour. Um, so, so you can in the everybody's setting is a little bit different. And again, I saw in the chat a lot of people saying we're meeting people where they're at, we're meeting patients where they are, and a lot of that too is the certainly on the AMU, it's an option for patients who can't go through the emergency room for whatever reason. But given the severity of withdrawal with medetomidine, it's probably not the best place for patients to be, right? You want them to be somewhere very highly monitored, actually, because of the severity of the withdrawal. But we are meeting patients where they're at too. Other alpha 2 agonists can be helpful, tizanidine, guanfacine, um, but they aren't they don't seem to be quite as active role as the clonidine. And then the antiemetics are super important. For some reason, ondansetron does not seem to work very well in this in medetomidine withdrawal. So we do olanzapine and prochlorperazine as our mainstays of the antiemetic treatment. And then I always like to just put another plug in here because a lot of times we get really focused on the alpha 2 withdrawal and we forget about the opioid withdrawal. And so really trying to just get the balance of your managing the alpha 2 agonist withdrawal, but you also can't get behind on those opioids. So that's something that's really important because I think that we undertreat sometimes the opioid withdrawal, and then patients are so uncomfortable they do leave the hospital. If and when nausea and vomiting is so severe that patients can't tolerate oral medication anymore, then the next step is to transfer them to a location that can give dexmedetomidine. So in our hospital system, that's the ICU. So patients are often transferred to the ICU for dexmedetomidine or Precedex. This is why that question about what the length of stay is varies so much, is because if patients will now often go to the ICU for at least a couple of days, and then come back to us on the AMU to figure out the discharge planning. I put this in case there's any hospital or ICU providers on here this is from the Penn ICU guide of how to manage medetomidine withdrawal with the dexmedetomidine. And the starting rate for the infusion they set is at 0.5, titrated up to a maximum of 1.5, or beyond that to 2.4 micrograms per kg per hour. We do not, at Bayview, we do not go up to this 2.4, mainly because we have found that our system works better if we leave it as a nurse managed protocol as opposed to a provider managed protocol. But each system is different. And so some places do provider driven protocols for their dexmedetomidine, and they can go up to those higher doses. 2.4 is the maximum infusion rate that even goes through the tubing. Adjunctive medications can be used, and the reason why I highlight ketamine here is because it can be really helpful, but I do want to highlight the dosing that can be used for ketamine. So this is a low dose. It's 0.1 to 0.3 mg per kg per hour. We've seen patients who get titrated up on ketamine to much higher doses, And that actually increases the blood pressure, increases the agitation. So you want to stay at this sub-dissociative level. Um, and then the other option for an adjunctive treatment would be propofol. If patients are still agitated after that, that's when I would consider benzodiazepine or phenobarbital for additional agitation response. For the hemodynamics, the clonidine and dexmedetomidine should improve blood pressure and heart rate. And it was mentioned on the other slide, but I didn't say it out loud. We're sort of treating to a goal of a blood pressure of 160/90. We're not necessarily going to normotensive here. We just want to be in a non-hypertensive urgency range. If you're on your max dose of Precedex, you're also doing clonidine, you're also doing, another anti sort of agitation medication, sedating medication, and your blood pressure or heart rate is still high, then I would focus on medication. And say the patient, if the patient now is sort of sedated, they're not agitated anymore, then really focus on the hemodynamics. Use the medications that you would to treat hypertensive emergency with these vital signs. So you have, just to recap there, you have the oral clonidine and other alpha-2 agonists. When those no longer are effective because the patient's nausea and vomiting is so severe, you transition to IV medications. Again, making sure you have the opioids on board. The dexmedetomidine is the mainstay of IV treatment. And then you can either add in additional sedating medications if needed, or blood pressure and heart rate medications as needed. Any questions about that? This is the Penn Center for Addiction and Addiction Medicine and Policy. They have a great guide both on medetomidine itself, but also on ICU management. And so there's I highlight it here because it's a little bit hard to find on the website, but it's this ICU medetomidine fentanyl withdrawal management strategy. You can click on that, and that downloads a separate document on ICU management. So why are we treating this so aggressively? Well, there can be complications. NSTEMI, so cardiac concerns, PRESS, which is brain changes, seizure activity, severe electrolyte disturbances, aspiration from all the vomiting, and intubation. We haven't really seen the PRESS or the seizures so much. NSTEMIs, we do sometimes see a troponin elevation. We certainly see lots of severe electrolyte disturbances. And we do have patients who have reported, my significant other or my friend died, at home from withdrawal from this. And I suspect that is that the severe electrolyte disturbances are probably the cause of death in the field from medetomidine withdrawal, maybe some aspiration as well. And then we do have a few people who have required intubation for airway protection. So as you can see, there are very dramatic clinical effects from medetomidine. And I suspect that we will see other severe syndromes from the other emerging drugs that are out there. We've seen these really high rates of ICU level care needed. So we have probably a 75% ICU level need of our patients who come in for medetomidine withdrawal. And that's associated with a very high cost. So Philadelphia had done a study, and the cost increased, the cost to care for opioid withdrawal with the addition of medetomidine withdrawal increased many millions, tens of millions in a quarter. And so what can be done to reduce the ICU level care? I welcome anyone's thoughts on here. What can be done to help sort of reduce the need for ICU level care? Christiana Care, in talking to Greg Warner and his team, has really recognized this as an issue, and they had times where their whole ICU was filled with people who had medetomidine withdrawal, and so they actually changed the hospital system, adjusted the dexmedetomidine to be able to be given on a step-down unit, and so they were able to reduce their ICU needs to about 20 to 30% by making that change. And that comes with a lot of nurse and provider education about how to manage it on a step down unit. But I think that it's certainly one option. Another concern is, how do we communicate all this to different providers, right? We're talking here, and I thank you all for being here and for listening, and I value your opinions on what you're seeing and how we respond to it. But how do we generally communicate to the hospitals or the doctors or the nurses or the social workers and the peers who are not on this, webinar, and who are not necessarily connected to the regional emerging drugs? How do we communicate what's out there and how to best treat it? Baltimore now has these cards that patients can get. The health department has created, actually, sorry, not Baltimore, but Maryland Health Department, cards that say, the drug supply may have medetomidine in it, and here's some guidelines of how to treat it, and here's where to learn more. So really, in that case, we're asking the patients to communicate, right, when we can't reach everyone. We do see a pretty high return to use rate for patients who leave the hospital after being treated for medetomidine withdrawal. A lot of times people are leaving in a self-directed discharge. And a lot of times they do return for treatment an additional time or 2 or 3. And so what can be done to reduce the return to use? As I discussed earlier, getting that conversation about medication for opioid use disorder, so methadone or buprenorphine, getting that in early can be really helpful. Setting patients up with a program near them that can help with those medications, so making sure they have some continuity of care. We have peer support in the hospital that can help link patients to care after the hospital has a hospitalization, but we don't have peers that follow them after the hospitalization. And I think that that's something that would be so important in helping as a resource for patients. And I know a lot of the patients that we're seeing are in Cecil County, and I know some folks on here are from Cecil County, and there are a lot of peer support and other sort of harm reduction programs out there. And so really just finding ways to reach more patients, for us to be able to reach more patients too. A few things that we don't know. We know there's a lot we don't know, but a few of the things we don't know. What are the long-term effects of medetomidine? So similar, we don't see any of these severe wounds like we do with xylazine. And again, that's probably related to the fact that the medetomidine binds so tightly to the alpha-2 agonist, and the xylazine have slightly different mechanism or receptors that they hit. So we're not seeing that, but I wonder, is there going to be long-term cardiac complications from having these swings of blood pressure that go so high and tachycardia that goes so high? And what other effects we'll see? Are there ways that we can predict who will have severe withdrawal or not? Not really. We've seen patients who come in who require an ICU stay one time and not the other. And there doesn't seem to be an order to that. So it's not always the first time they're here they require the ICU, or the second time. There is data from the pediatric ICUs that use dexmedetomidine regularly for procedural sedation and post-procedural sedation. And they've found that the dose of dexmedetomidine, the duration that someone's on it, and then whether or not they have concomitant opioid used for analgesia, some of those factors play into it, but it's not perfect prediction there on who will develop the withdrawal. And then this question of reversal agent, there is an approved veterinary reversal agent, um, but um, I don't see a role for it in human use at this time, especially with chronic medetomidine exposure, because as you can see how significant the withdrawal is, um, if you suddenly put somebody into withdrawal from the medetomidine, you have a very, very high risk of extremely high rebound blood pressure and tachycardia, severe vomiting. And so I don't think that there's a benefit. If you're thinking about risk and benefit of the withdrawal of the reversal agent, I don't see a benefit for human medicine right now, especially because, again, that naloxone is doing the job of reversing the respiratory depression in an overdose because there's still fentanyl involved in it. So the naloxone is really doing that reversal job that we need it to. And then what's the next drug? I actually have no idea, but maybe you all can tell me what you're seeing. And I get lots of emails now, newsletters and things. But I think that we all just again, being aware of the fact that there's so many substances out there, and really listening to our patients and our community, and trying to be aware of the trends that are there, is the best way to see. So I will stop talking now. Here's my summary. Basically, if it doesn't look like, I just said I would stop talking, I didn't stop. But if it doesn't look like typical withdrawal, ask a friend, check the local supply. The drug supply is dangerous and unpredictable. Medetomidine intoxication is really defined by sedation and bradycardia. Still use naloxone. And then withdrawal is very severe and should be treated aggressively. All right, now I really will stop.
Thank you so much. This
Yeah.
was a wonderful presentation, as always. I think such an important topic. There have been some questions and comments into the chat. So earlier, someone did ask, does medetomidine have a street name? And then someone else did comment with it. I've heard it called Rhino Drink, but I wanted to be sure to bring that up if you know any other street name for it.
Yeah, I think that's what I've heard too. And yeah, I think like Trank or Rhino Trank, yeah.
Okay. And then if others have questions, please feel free to put them in the chat or you can unmute. We do have some time, so we are happy to take questions now. I did see just now put into the chat, can you send out the slides? Yes, we will be sending out the slides, and a recording of today's training will also be available on our website within 1 week. But the slides, and they will be sent to you by tomorrow. Another just comment in the chat is, where is it? Apologies. So we need some more sponsors like AA or probation officers. With NA. There are not enough people that attend unless required by a judge.
Yeah, I think that NA and AA can be very helpful for a lot of people. It's not for everyone. And sometimes, honestly, even if it is required by a judge, sometimes there is a benefit that comes from it. But again, I do think that this also speaks to those need for harm reduction and peer support as well. And just linking people to the level of care that they are sort of interested and able to do, right? I don't know how many daily drug users there are in the Metro Baltimore area. If anybody on here does, I'd be happy to hear that. And medetomidine, and I mean, fentanyl pills are cheap. They're $3 for a pill. And that's going to be enough to over somebody who has not used any opioids. If they use a pill of fentanyl, they would probably overdose. It's pretty high dose. And the fentanyl, I say fentanyl, I know your question is medetomidine, but for Dan Morheim, but the fentanyl and medetomidine so far are always sold together. So people aren't necessarily going out and buying a pill of medetomidine, but they're buying here in Baltimore a pill of fentanyl, or in the Cecil County and Philly area, they'll say a bag or a bundle. And again, so it's like for a pill or a bag, it's probably about $3. And then if somebody's buying, say, buprenorphine or Suboxone on the street, that's going to cost like $10. So it's much cheaper to get fentanyl and medetomidine than it is to get Suboxone. Yeah, I agree with Monique here. There, you know, it's really important to work with patients who use drugs, about counseling, that the supply is always changing. And so you never um, never want to use alone. If you've gone a while without using, you have to be really, 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 really careful. This is especially important in people who are, say, incarcerated, who, when they went to prison or jail, it was, one drug, and now it's a completely other potency and a completely other drug. So it's really, really hard to convey that information to everyone who needs to hear it. Is there evidence that engagement, retention, return to opioid use, and ultimately reduce adverse? For Amy's question, is there evidence that engagement in or retention in MOUD treatment reduces opioid return to use, and ultimately reduces adverse impacts of medetomidine? I don't think this has been looked at in medetomidine. If anyone out here knows differently about that in relation to medetomidine, but yes, MOUD engagement can reduce opioid overdoses, and reduce things like, HIV acquisition, Hep C, other infectious disease things. It can reduce wounds. So there are a lot of benefits to MOUD, but I don't know how in particular it plays with the medetomidine. And yes, and I actually didn't have a chance to look at the last week's RAD report, but the slides that I put in were from January to May of this year. And then Sonia says, since the withdrawal from medetomidine is so severe, when combating it with clonidine, ketamine, etc., the side effects from those drugs compound moving forward with withdrawal successfully. It doesn't seem so. Honestly, the biggest issue with treating withdrawal is that people are so uncomfortable for so long that they end up leaving the hospital early before treatment is completed. It's not necessarily the clonidine having side effects. So people tolerate the clonidine really well because the medetomidine is so much more potent than the clonidine that we're giving. So it's actually usually not side effects from what we're giving them, but actually like under treatment. Okay, great question. Is it Xiaolin Ding about testing for medetomidine? There's very few places that have testing available. So actually at Hopkins, we just rolled out urine testing 2 weeks ago in our urine drug testing. And that is on the extended toxicology panel, which is mass spec, and it's not the screening toxicology test. So it actually takes 4 to 5 days to come back. So for clinical medicine, it's actually not there isn't really a rapid urine test or a rapid screening test that is helpful for diagnosing medetomidine. It's really like the clinical situation, because I agree, like Easton and the Eastern Shore like will probably is they are you are probably seeing some of this, um, and um, and really it's going to be about the clinical scenario. There are some places that do have the ability to test for medetomidine, but it's not widespread. You can use a test strip, or you could provide patients with test strips, right, to test their drugs. And there's like some like a theory. There's hypothetically, you could also use the test strip in urine for somebody who just used, but the medetomidine gets metabolized really quickly. So it's not going to be the most accurate. Um, I have not used, this is from Mohammed always. Can you do methyl dopa instead of clonidine? Yeah, and then Sani, the excellent pharmacist, says did a perfect answer, which is methyl dopa is a lot less potent than clonidine, is a prodrug, so it takes a while to work and has a much shorter half-life, so harder to offer a quick taper in the patient. So it is harder to offer a quick taper. The patient improves versus something like clonidine, so likely not ideal in cases like these. We haven't used methyl dopa here. And then Angela answered the question about how many people here in the Baltimore Metro use drugs. 300,000 residents, and 14% use illicit drugs approximately. So, all right.
So I know that we are at time. I know we are just after one. So if you want to take another question, we can, or I can give another plug for Max that we are happy to answer these questions if you want to contact our consultation warm line. And I could even get you in touch perhaps with Dr. Nahash Vijan and to answer some of your questions. So I'm not sure kind of what your timeline is if you want to answer another question, or we can definitely start to wrap up and definitely coordinate to answer some of these other questions.
Yeah, I'm happy to like stick around for a few minutes if people want to chat. But please feel free to reach out by email. I have my email here. If anything comes up or if I can be helpful in any way.
Thank you so much. And another just kind of quick overview for receiving CME or CEU credit for today's webinar. If you have been online for the duration for the whole presentation, your attendance has been verified in Oasis, our learning management platform. So you can log in and you can access your evaluation survey. That does need to be completed within 7 days from today. So by next Monday at the end of the day. And then you'll be able to download your CME or your CEU certificate from there. So thank you everyone for joining. Yes, we can stay on for another minute. And if anything kind of comes up at the end, you can email or you can contact Max.